Question 1. A patient is diagnosed with chronic hypertension and is admitted to the hospital for a routine checkup. The doctor documents a diagnosis of hypertension without specifying whether it is controlled or uncontrolled. What is the correct way to code this diagnosis? A. Code the hypertension diagnosis as unspecified, or B. Code the hypertension diagnosis as a controlled, or C. Code the hypertension diagnosis as uncontrolled, or D. Code the hypertension diagnosis with an additional code for a comorbidity. Answer A. Code the hypertension diagnosis as unspecified explanation. In ICD coding, if the documentation does not specify whether the hypertension is controlled or uncontrolled, the coder must assign the appropriate unspecified code. When the condition is not clearly stated as controlled or uncontrolled, it should be coded as unspecified. This approach follows the ICD guidelines, which emphasize using codes that reflect the information available in a patient's record. Additionally, this avoids making assumptions about the patient's condition that are not supported by the documented diagnosis. Coding as unspecified should be avoided only when the documentation clearly supports a more specific diagnosis, such as a controlled or uncontrolled, to ensure accurate reimbursement and clinical data. Question 2. Mr. Allen, a 55-year-old male, visits his primary care physician complaining of chest pain, shortness of breath, and dizziness. The physician performs an ECG and diagnoses Mr. Allen with acute myocardial infarction (MI). In addition, the physician notes that Mr. Allen has a history of type 2 diabetes and hypertension, which have been under control with medication. Based on this information, what is the correct sequencing for the codes? A. Acute MI code followed by diabetes and hypertension codes. B. Diabetes and hypertension codes followed by the acute MI code. C. Only the acute MI code should be used. D. A code for dizziness should be added. And so A. Acute MI code followed by diabetes and hypertension codes. Explanation. In ICD coding, when multiple diagnoses are documented, the primary or principal diagnosis should be sequenced first. The acute myocardial infarction (MI) is the primary reason for Mr. Allen's visit and the main condition treated, so it should be coded first. The diabetes and hypertension codes, while important for understanding the medical history, are secondary diagnoses and should be sequenced afterward. The coding guidelines specify that acute conditions should always be prioritized in the sequence. Comorbidities, such as diabetes and hypertension, are important but do not alter the sequencing when the acute condition is the reason for hospitalization or treatment. Question 3. Scenario MS. Grace, a 70-year-old woman, presents to her physician with complaints of joint pain and stiffness in her knees and hips. She has a history of osteoarthritis OA in both knees and hips. Upon examination, the physician notes that her symptoms have worsened recently. After reviewing her medical history and performing a physical exam, the physician documents an exacerbation of her OA in both knees. What is the most accurate way to code this condition? A. Code for osteoarthritis OA with a secondary code for the exacerbation of OA. B. Code for osteoarthritis with an unspecified code for the exacerbation. C. Use a code for osteoarthritis with an additional code indicating a flare-up of symptoms. D. Use the osteoarthritis code with the exacerbation explicitly stated in the code description. Answer D. Use the osteoarthritis code with the exacerbation explicitly stated in the code description. Explanation. In ICD coding, when a condition such as osteoarthritis is documented with an exacerbation, the coder should use the code that includes both the primary condition and the specific symptom or situation, like an exacerbation or flare-up, if it is explicitly stated, if the documentation clearly states the exacerbation or flare-up. Osteoarthritis, this information should be reflected in the code. If a code specifically denotes an exacerbation, it is critical to use this code to capture the full clinical picture. Using unspecified codes should be avoided when more specific information is provided in the medical record. It ensures that the diagnosis reflects both the chronic condition, osteoarthritis, and the acute situation, exacerbation, leading to more accurate reimbursement and treatment. Notice. Question 4. A patient presents with a history of chronic obstructive pulmonary disease (COPD) and is diagnosed with an acute exacerbation of COPD. The physician documents that the patient also has a history of tobacco use, but there is no mention of the current smoking status. Which of the following is the most accurate coding approach? A. Code only for COPD and the acute exacerbation without referencing tobacco use. B. Code COPD with an additional code for tobacco use disorder and specify the exacerbation. C. Code COPD and exacerbation with and note that tobacco use is documented as a history only. D. Code COPT acute exacerbation and tobacco use disorder, including the patient's history. Answer: B. Code COPT with an additional code for tobacco use disorder and specify the exacerbation. Explanation: in ICD-10, when coding a condition like COPT with an exacerbation, it is essential to specify both the condition and the exacerbation. The guidelines recommend coding the underlying condition first, followed by any related conditions. In this case, while the tobacco use is documented as a history, it is important to code tobacco disorder if it is relevant to the patient's condition, particularly as it has contributed to the development of COPT. However, since the physician did not specify whether the patient is actively smoking, the tobacco use disorder code should reflect the historical aspect, not an active smoking condition. The exacerbation of COPT should be coded separately to reflect the acute nature of the patient's symptoms. Question 5. Mrs. Davis, a 63-year-old female, presents with a fever, cough, and chest pain. Upon examination, the physician diagnoses her with pneumonia and notes that she also has a chronic history of asthma. The physician orders a chest X-ray, which confirms bacterial pneumonia in the right lung. What is the appropriate sequence of coding for this patient? A. Pneumonia code followed by asthma code, noting the chronic condition. B. Asthma code first, followed by the pneumonia code. C. Code for bacterial pneumonia alone, as asthma is unrelated to the pneumonia. D. Code pneumonia with a complication code for the asthma. Answer: A. Pneumonia code followed by asthma code, noting the chronic condition. Explanation: in ICD-10 coding, the primary condition is always sequenced first. Since Mrs. Davis' primary issue is pneumonia, the pneumonia code should come first. The chronic condition of asthma, while relevant, is a secondary condition and should be sequenced afterward. The asthma code will specify that the condition is chronic, and if the physician has provided documentation indicate that asthma contributed to or worsened the pneumonia, that should also be reflected in the coding. The guidelines for coding chronic conditions suggest that they should be coded as secondary diagnoses unless the chronic condition is the primary reason for the patient encounter. Question 6. A patient presents to the clinic with a history of diabetes mellitus type 2, which is currently well controlled with medication. The physician diagnoses the patient with diabetic neuropathy in the feet. The patient also reports occasional tingling and numbness, but there is no documentation that the neuropathy is causing significant functional impairment. What is the best way to code this condition? A. Use the diabetes code followed by the diabetic neuropathy code. B. Code for diabetes type 2 with neuropathy, specifying the lack of impairment. C. Code for diabetic neuropathy without the diabetes type 2 code. D. Code for diabetes type 2 without mentioning neuropathy, as it is well controlled. Answer: A. Use a diabetes code followed by the diabetic neuropathy code. Explanation: in ICD-10 coding, when a patient has diabetes with a complication such as neuropathy, both conditions must be coded. The primary condition, diabetes type 2, should be sequenced first, followed by the secondary diagnosis of diabetic neuropathy. Even if the neuropathy is not causing significant impairment, it still needs to be coded as a complication of diabetes according to the ICD-10 guidelines. The diabetic neuropathy code captures the manifestation of the diabetes, and it is necessary to code both the underlying condition, diabetes, and its complications, neuropathy. If the neuropathy were causing functional impairment, that would affect the severity and additional code selection, but the principles apply. Question 7. A patient with a history of obesity and hypertension visits the clinic for a routine follow-up. The physician documents that the patient has gained significant weight over the past few months and their hypertension is now uncontrolled. The physician also notes that the patient is on medication for both conditions but has not been compliant with their prescribed treatment regimen. How should this be coded? A. Code for obesity first, followed by hypertension, with an additional code for uncontrolled hypertension. B. Code hypertension first, followed by obesity, noting the uncontrolled nature of hypertension. C. Code for obesity with hypertension listed as a secondary diagnosis. D. Code hypertension as uncontrolled only without including the obesity diagnosis. Answer: B. Code hypertension first, followed by obesity, noting the uncontrolled nature of hypertension. Explanation: the ICD-10 guidelines recommend coding the primary diagnosis first, which in this case is the uncontrolled hypertension. Since the patient's hypertension is now uncontrolled, it takes precedence as the main condition treated during this visit. The obesity diagnosis is secondary and should be listed afterward. In cases where both conditions are chronic, the coding guidelines dictate that the more urgent or clinically significant condition should be sequenced first. Additionally, since the hypertension is specifically noted as uncontrolled, it is essential to code it with that level of specificity to reflect the severity of the condition and ensure appropriate reimbursement. Obesity, although relevant, is secondary to the hypertension in this scenario. Question 8. Mr. John, a 50-year-old male, presents with severe abdominal pain, nausea, and vomiting. Upon examination, the physician diagnoses Mr. John with acute pancreatitis. Additionally, the physician notes that Mr. John has a history of alcohol abuse. He was admitted to the hospital for the management of his condition. What is the correct coding approach for this case? A. Code for acute pancreatitis, followed by the alcohol abuse code. B. Code for acute pancreatitis without alcohol abuse as it is not relevant. C. Code alcohol abuse first, followed by the acute pancreatitis code. D. Use a code for pancreatitis with an unspecified etiology. Answer A. Code for acute pancreatitis, followed by the alcohol abuse code. Explanation. In this case, the acute pancreatitis is the primary reason for the patient's visit, and as such it should be coded first. However, since alcohol abuse is often a contributing factor to pancreatitis, it should also be coded. The guidelines indicate that if the condition is clearly related to alcohol use, the alcohol abuse code should be added as secondary diagnosis. Even if the alcohol abuse is not actively contributing to the patient's acute episode, it is relevant in understanding the patient's medical history and should be coded to reflect the potential cause of the pancreatitis. This ensures that the coding is accurate and appropriately reflects the patient's clinical presentation and risk factors. Question 9. A patient presents with a diagnosed urinary tract infection (UT) and the physician orders a urine culture. The culture reveals the presence of Escherichia coli. The physician also notes that the infection is limited to the lower urinary tract and the patient has no signs of systemic infection. What is the appropriate ICD code for this diagnosis? A. Code for urinary tract infection (UT) with a specific code for Escherichia coli. B. Code for UT unspecified as the infection is limited to the lower urinary tract. C. Code for a lower urinary tract infection with an additional code for the organism. D. Code for UT with an unspecified organism. Answer C. Code for a low urinary tract infection with an additional code for the organism. Explanation. For a urinary tract infection caused by a specific organism like Escherichia coli, the ICD guidelines recommend coding the infection based on both the site of the infection, lower urinary tract, and the organism E. coli. This ensures that the medical record accurately reflects both the location and etiology of the infection. The UT should specify the lower urinary tract, and the additional code for the organism E. coli is required to provide a complete picture of the infection. This is consistent with the ICD rule of using codes that capture both the condition and its underlying cause when available and documented. Question 10. A patient is diagnosed with a non-healing ulcer on the right foot caused by diabetic neuropathy. The physician notes that the ulcer is not infected and there is no evidence of gangrene. What is the most accurate coding approach for this patient? A. Code for diabetic neuropathy with an additional code for the foot ulcer. B. Code for diabetic neuropathy without coding the foot ulcer. C. Code for the non-healing ulcer as the primary diagnosis, followed by diabetic neuropathy. D. Code for diabetic neuropathy and code the foot ulcer with a code for gangrene. Answer A. Code for diabetic neuropathy with an additional code for the foot ulcer. Explanation. In ICD, when a patient has a diabetic complication like neuropathy that leads to another condition such as an ulcer, both conditions should be coded. The primary diagnosis should be the diabetic neuropathy code as it is the underlying cause of the ulcer. The non-healing foot ulcer should be coded as a secondary diagnosis. This approach follows the ICD guidelines, which recommend coding complications arising from chronic conditions like diabetes. Since the ulcer is not infected or associated with gangrene, it should not be coded as such. The ulcer's non-healing nature should be acknowledged in the coding to capture the severity of the condition. Question 11. A 40-year-old male presents to the emergency department with severe chest pain. The physician diagnoses him with an acute myocardial infarction (AMI) and documents that the patient has a history of smoking and hyperlipidemia. The physician orders a complete workup which confirms the presence of ischemia and myocardial tissue damage. The patient is admitted for treatment. How should this case be coded? A. Code for acute myocardial infarction followed by codes for hyperlipidemia and smoking. B. Code for acute myocardial infarction with smoking as a contributing factor. C. Code for acute myocardial infarction only as it is the primary diagnosis. D. Code for myocardial ischemia followed by smoking and hyperlipidemia. Answer A. Code for acute myocardial infarction followed by codes for hyperlipidemia and smoking. Explanation. The acute myocardial infarction (AMI) is the primary reason for the patient's visit and should be coded first. The physician has identified risk factors, including smoking and hyperlipidemia, that contribute to the patient's condition. Both smoking and hyperlipidemia should be coded as secondary diagnoses as they are factors to the development of AMI. Coding these conditions ensures a comprehensive representation of the patient's medical history and provides context for the myocardial infarction. In this case, the AMI is the focus of treatment and the other conditions are considered contributory but secondary. Question 12. A patient with a history of gastroesophageal reflux disease (GERD) presents to the clinic with worsening heartburn. The physician notes that the patient's GERD has not been well controlled despite medication and lifestyle changes. The patient is also overweight. What is the most accurate approach to coding for this visit? A. Code for GERD with an additional code for obesity as a contributing factor. B. Code for GERD only as obesity is not a significant factor. C. Code for obesity followed by GERD, specifying that the condition is uncontrolled. D. Code for GERD with a code for obesity but without specifying the uncontrolled nature of GERD. Answer A. Code for GERD with an additional code for obesity is a contributing factor. Explanation. In this case, gastroesophageal reflux disease (GERD) is the primary diagnosis and should be coded first. Since the physician has documented that the patient's GERD is not well controlled, it is important to indicate the severity of the condition even if uncontrolled is not explicitly mentioned. Obesity is a contributing factor to GERD and coded as a secondary diagnosis. Obesity is known to exacerbate GERD symptoms and can impact treatment options. The coding guidelines recommend documenting conditions that contribute to the primary diagnosis, and obesity is directly related to the patient's GERD severity. Question 13. A 75-year-old woman presents with symptoms of acute confusion and short-term memory loss. The physician diagnoses her with a urinary tract infection (UT) and documents that the infection may be contributing to her cognitive symptoms. How should the UT and confusion be coded? A. Code for UT followed by a code for acute confusion. B. Code for UT with acute confusion sequence second as a complication. C. Code for UT only as confusion is not directly related. D. Code for acute confusion first, followed by UT as the secondary diagnosis. Answer A. Code for UT followed by a code for acute confusion. Explanation. In ICD, the primary diagnosis should reflect the condition that is being treated most urgently. In this case, the UT is the primary issue and it is responsible for triggering the patient's confusion. Therefore, the UT code should be sequenced first. The acute confusion is a secondary condition as it is a complication of the UT and should be coded second. Guidelines specify that when an infection leads to cognitive dysfunction, the infection is typically considered the underlying cause, making it the primary diagnosis. Additionally, acute confusion is often coded as the secondary diagnosis in this context. Question 14. A 60-year-old male with a history of type 2 diabetes and hypertension presents to his primary care physician for a routine checkup. The physician documents that the patient has chronic kidney disease (CKD) stage 2 and is on medication for both diabetes and hypertension. How should this case be coded? A. Code for type 2 diabetes followed by hypertension and CKD stage 2. B. Code for CKD first followed by type 2 diabetes and hypertension. C. Code for type 2 diabetes only with hypertension and CKD as secondary diagnoses. D. Code for hypertension first followed by diabetes and E. Answer. B. Code for CKD first, followed by type 2 diabetes and hypertension. Explanation. In this scenario, the chronic kidney disease (CKD) is the primary diagnosis because it is a progressive and potentially life-threatening condition that requires ongoing monitoring and management. According to the ICD guidelines, CKD should be coded first if it is the condition most closely related to the encounter. The secondary diagnosis, type 2 diabetes and hypertension, should be listed afterward, as they both contribute to the progression of CKD, but do not represent the immediate clinical focus of this visit. This ensures that the patient's medical conditions are represented accurately in terms of both their severity and relevance to the visit. Question 15. A patient with a history of asthma and seasonal allergies visits the clinic complaining of shortness of breath, wheezing, and coughing, which have been exacerbated by recent environmental changes. The physician diagnoses the patient with an asthma exacerbation triggered by environmental allergies. How should this encounter be coded? A code for asthma exacerbation followed by seasonal allergies as a secondary diagnosis. B code for asthma followed by an unspecified allergy code. C code for asthma with environmental allergies as a coexisting condition but without exacerbation. D code for asthma exacerbation only as allergies are not relevant to the exacerbation. Answer A code for asthma exacerbation followed by seasonal allergies as a secondary diagnosis. Explanation. In this case, the asthma exacerbation is the primary diagnosis as it is the condition being treated and managed. Environmental allergies are documented as the trigger for the asthma exacerbation, so the seasonal allergy code should be listed as a secondary diagnosis to show that it is contributing to the patient's acute symptoms. The guidelines specify that when a chronic condition like asthma is exacerbated by an environmental factor, both the exacerbation and the underlying condition, allergy in this case, should be coded. This helps fully reflect the cause and effect relationship between the conditions. Question 16. A 50-year-old female presents to the clinic for a follow-up visit after being diagnosed with breast cancer. She has completed her chemotherapy and is now undergoing radiation therapy. The physician documents that she is experiencing mild side effects from the treatment, including fatigue and skin irritation. How should this case be coded? A code for breast cancer, followed by codes for chemotherapy and radiation therapy. B code for breast cancer, followed by codes for side effects of chemotherapy and radiation. C code for breast cancer and secondary codes for fatigue and skin irritation without specifying treatment. D code for fatigue and skin irritation first, followed by breast cancer as a secondary condition. Answer B code for breast cancer, followed by codes for side effects of chemotherapy and radiation. Explanation. When coding for a patient undergoing cancer treatment, the primary diagnosis is breast cancer. Since the patient is experiencing side effects from chemotherapy and radiation therapy, these should also be coded as secondary diagnoses. The side effects are clearly related to the treatment, and encoding them helps document the impact. Cancer therapy on the patient's health. This approach aligns with ICD guidelines, which state that side effects from cancer treatment should be coded when they are significant enough to require treatment or impact the patient's quality of life. Question 17. A patient presents with severe knee pain, which has been worsening over the past few weeks. The physician diagnoses the patient with osteoarthritis of the knee. The physician also notes that the patient has a history of obesity, which may be contributing to the condition. How should this case be coded? A code for osteoarthritis of the knee followed by obesity as a contributing factor. B code for osteoarthritis of the knee and obesity without specifying the contribution of obesity. C code for obesity only with osteoarthritis of the knee as a secondary diagnosis. D code for osteoarthritis of the knee only as obesity is irrelevant to the condition. Answer A code for osteoarthritis of the knee followed by obesity as a contributing factor. Explanation. In this case, osteoarthritis of the knee is the primary diagnosis as it is the condition causing the patient's pain and functional impairment. Obesity is a contributing factor that can worsen osteoarthritis by placing additional stress on the knee joints. According to ICD coding guidelines, contributing conditions should be listed as second diagnoses when they are clinically relevant and impact the primary condition. Obesity should be coded to reflect its contribution to the patient's knee osteoarthritis, even if it is not the primary focus of the visit. Question 18. A 55-year-old male with a history of stroke and hypertension presents with a complaint of blurry vision and dizziness. The physician documents that the patient's blood pressure is elevated, and they suspect that these symptoms may be related to a transient ischemic attack TIA. The physician orders imaging studies to confirm the diagnosis. What is the correct coding approach for this visit? A code for transient ischemic attack with hypertension as a contributing factor. B code for hypertension first, followed by TIA as a secondary diagnosis. C code for TIA only as it is the primary diagnosis. D code for stroke and hypertension with a secondary diagnosis of TIA. Answer A. Code for transient ischemic attack with hypertension as a contributing factor. Explanation: the transient ischemic attack TIA is the primary condition being evaluated, and it should be coded as the primary diagnosis. Hypertension is a known risk factor for TIAs, and it should be listed as a secondary diagnosis to reflect its contribution to the patient's symptoms. The ICD guidelines recommend coding the condition that is currently evaluated or treated as the primary diagnosis, while hypertension is a contributing factor to the TIA. It is not the immediate concern of the visit and should therefore be sequenced as a secondary diagnosis. Question 19. A 30-year-old female presents with severe abdominal pain and is diagnosed with an acute appendicitis. The physician notes that the patient is pregnant, but there is no indication that the appendicitis is related to the pregnancy. How should this case be coded? A. Code for acute appendicitis with a secondary code for pregnancy. B. Code for acute appendicitis only as pregnancy is not relevant to the diagnosis. C. Code for pregnancy first, followed by appendicitis as a secondary diagnosis. D. Code for pregnancy-related appendicitis. Answer A. Code for acute appendicitis with a secondary code for pregnancy. Explanation: in this case, the acute appendicitis is the primary condition and should be coded first, as it is the reason for the patient's visit and treatment. Pregnancy is not the primary cause of the appendicitis, but it is important to note that the patient is pregnant. A secondary code for pregnancy should be included to reflect the patient's pregnancy status. This coding ensures that both the condition being treated and the patient's pregnancy status are accurately documented according to ICD guidelines. Question 20. A patient presents for a follow-up visit after being treated for a fracture of the left wrist. The physician documents that the fracture has healed and the patient is now experiencing mild stiffness and discomfort with some limited range of motion. What is the most accurate way to code this encounter? A. Code for healed fracture of the left wrist with additional codes for stiffness and limited range of motion. B. Code for the healed fracture only without including stiffness or limited range of motion. C. Code for stiffness and limited range of motion as the primary diagnosis. D. Code for a non-healing fracture of the left wrist. Answer A. Code for healed fracture of the left wrist with additional codes for stiffness and limited range of motion. Explanation: in this scenario, the fracture of the left wrist has healed, but the patient is still experiencing stiffness and limited range of motion. The healed fracture should be coded as the primary diagnosis to reflect the patient's medical history. Additionally, any ongoing symptoms or complications related to the healed fracture, such as stiffness and limited motion, should be coded as secondary diagnosis to ensure a complete representation of the patient's current condition. This approach aligns with the ICD guidelines, which encourage coding both the healed condition and any residual symptoms or complications. Question 21. A 45-year-old female with a history of asthma presents to the emergency department with difficulty breathing and wheezing. The physician diagnoses an asthma exacerbation due to a recent upper respiratory infection, URI. The patient is treated with nebulized bronchodilators and corticosteroids. What is the appropriate coding for this encounter? A. Code for asthma exacerbation, followed by URI as a contributing factor. B. Code for URI followed by asthma exacerbation as a secondary diagnosis. C. Code for asthma exacerbation with no mention of URI. D. Code for asthma followed by the bronchodilator treatment. Answer A. Code for asthma exacerbation followed by URI as a contributing factor. Explanation: in this case, the primary diagnosis is the asthma exacerbation as it is a reason for the visit and the condition being treated. The upper respiratory infection, URI, is a contributing factor and it should be coded as a secondary diagnosis as URIs often trigger asthma exacerbations. The coding should reflect the underlying cause of the exacerbation, URI, prioritizing the asthma exacerbation as the primary diagnosis. Question 22. A 72-year-old male with a history of chronic obstructive pulmonary disease (COPD) presents with increased shortness of breath, productive cough, and fever. The physician diagnoses a COPD exacerbation caused by a bacterial respiratory infection. How should this be coded? A. Code for COPD exacerbation, followed by bacterial respiratory infection as a secondary diagnosis. B. Code for COPD exacerbation only. C. Code for the bacterial infection as the primary diagnosis. D. Code for COPD, followed by acute respiratory failure. Answer A. Code for COPD exacerbation, followed by bacterial respiratory infection as a secondary diagnosis. Explanation: COPD exacerbations are often caused by respiratory infections, and in this case, the primary diagnosis is the COPD exacerbation, which is the reason for the visit. The bacterial respiratory infection is a contributing factor to the exacerbation and should be listed as a secondary diagnosis. This approach aligns with guidelines which specify that exacerbations of chronic conditions should be coded first when they are the reason for the visit. Question 23. A 60-year-old male presents with fatigue, dizziness, and palpitations. The physician diagnoses him with atrial fibrillation and documents that his heart rate is irregular. The patient is prescribed anticoagulation therapy to prevent thromboembolic complications. How should this encounter be coded? A. Code for atrial fibrillation, followed by anticoagulation therapy as a secondary diagnosis. B. Code for atrial fibrillation with heart rate irregularity and prescribe anticoagulation therapy. C. Code for atrial fibrillation with a secondary diagnosis of anticoagulation therapy. D. Code for atrial fibrillation and heart rate irregularity as the primary diagnosis. Answer: B. Code for atrial fibrillation with heart rate irregularity and prescribe anticoagulation therapy. Explanation: the primary diagnosis is atrial fibrillation as it is the main condition being treated and managed. Irregular heart rate is a characteristic symptom of atrial fibrillation and should not be coded as a separate diagnosis. The physician's prescription of anticoagulation therapy should be noted as part of the treatment plan. Does not require separate code unless complication or adverse effect arises from the therapy. This approach provides clear representation of the patient's condition and the necessary treatment plan. Question 24. A 34-year-old female presents with unexplained weight loss, fatigue, and excessive thirst. After conducting tests, the physician diagnoses her with type 1 diabetes mellitus and begins insulin therapy. What is the appropriate coding for this encounter? A. Code for type 1 diabetes, followed by insulin therapy. B. Code for type 1 diabetes only. C. Code for excessive thirst and weight loss with type 1 diabetes as a secondary diagnosis. D. Code for type 1 diabetes and complications like dehydration or electrolyte imbalance. Answer: A. Code for type 1 diabetes, followed by insulin therapy. Explanation: type 1 diabetes mellitus is the primary diagnosis as it is the cause of the patient's symptoms, while the patient's symptoms, weight loss, fatigue, and excessive thirst, are important for diagnosis. They are secondary to the primary diagnosis of diabetes. Insulin therapy is the treatment for managing type 1 diabetes, but it does not need to be coded separately unless there are adverse effects or complications related to the insulin. This coding strategy prioritizes the underlying condition and follows the treatment plan. Question 25. A 55-year-old female presents to the clinic with symptoms of depression and chronic fatigue. The physician diagnoses her with major depressive disorder (MDD) and states that the fatigue is likely a result of the depression. How should this encounter be coded? A. Code for major depressive disorder with chronic fatigue as a secondary diagnosis. B. Code for major depressive disorder including fatigue as part of the condition. C. Code for chronic fatigue followed by major depressive disorder as a secondary diagnosis. D. Code for major depressive disorder only as fatigue is part of the disorder. Answer: B. Code for major depressive disorder including fatigue as part of the condition. Explanation: major depressive disorder (MDD) is the primary diagnosis as it is the main condition being treated. Fatigue is a common symptom of depression and it should be coded as part of the disorder rather than as a separate diagnosis. Coding guidelines suggest that when symptoms of a condition are integral to that condition, they should be included in the diag and not listed as separate conditions. This ensures that the medical record accurately reflects the relationship between the depression and its symptoms. Question 26. A 47-year-old male with a history of hypertension presents for a routine checkup. The physician notes that the patient's blood pressure is elevated, but he has not been consistently following his prescribed medication regimen. What is the appropriate coding for this encounter? A. Code for elevated blood pressure with secondary code for hypertension. B. Code for hypertension followed by non-compliance with prescribed medication. C. Code for hypertension only. D. Code for elevated blood pressure as the primary diagnosis. Answer: B. Code for hypertension followed by non-compliance with prescribed medication. Explanation: The primary diagnosis is hypertension, as it is the underlying chronic condition being managed. Since the patient's blood pressure is elevated due to non-compliance with medication, non-compliance with prescribed medication should be coded as a secondary diagnosis. This approach reflects the underlying condition, hypertension, and highlights the non-compliance in the patient's current health status. Elevation of blood pressure is understood to be a symptom of the patient's ongoing hypertension. Question 27. A 60-year-old female with a history of osteoarthritis presents with severe pain in her right knee. The physician examines the knee and diagnoses it with an exacerbation of osteoarthritis with no signs of infection or trauma. How should this encounter be coded? A. Code for osteoarthritis exacerbation with no further specifications. B. Code for osteoarthritis followed by pain in the knees. A secondary diagnosis. C. Code for osteoarthritis exacerbation with a secondary code for pain management. D. Code for osteoarthritis only, as the exacerbation is not necessary to document. Answer A. Code for osteoarthritis exacerbation with no further specifications. Explanation. In this scenario, the primary diagnosis is the exacerbation of osteoarthritis, as this is the condition causing the patient's symptoms and requiring treatment. The pain in the knee is a common symptom of osteoarthritis and does not require a separate code. The exacerbation of osteoarthritis should be coded as the primary diagnosis, as it is the focus of the current treatment. The pain is understood to be part of the exacerbation of the condition. Question 28. A 70-year-old male presents with progressive memory loss and confusion. The physician diagnoses him with Alzheimer's disease and recommends further neuropsychological testing. How should this encounter be coded? A. Code for Alzheimer's disease only. B. Code for Alzheimer's disease with cognitive impairment as secondary diagnosis. C. Code for cognitive impairment followed by Alzheimer's disease. D. Code for Alzheimer's disease with secondary code for neuropsychological testing. Answer A. Code for Alzheimer's disease only. Explanation. Alzheimer's disease is the primary diagnosis in this scenario, as it is the underlying condition causing the patient's memory loss and confusion. The cognitive impairment is a symptom of the disease and does not need to be separately coded. The focus of the visit is the diagnosis of Alzheimer's disease, and the recommended neuropsychological testing does not require separate diagnosis unless specific warranted. Therefore, the Alzheimer's disease code should be listed as the only diagnosis. Question 29. A 25-year-old male presents to the clinic with acute back pain after lifting a heavy object at work. The physician diagnoses him with a lumbar strain and advises physical therapy. How should this encounter be coded? A. Code for lumbar strain only. B. Code for lumbar strain with a secondary code for work-related injury. C. Code for back pain followed by lumbar strain. D. Code for work-related injury followed by lumbar strain. Answer B. Code for lumbar strain with a secondary code for work-related injury. Explanation. The primary diagnosis is lumbar strain, as it is the condition being treated and causing the patient's symptoms. Since the injury occurred while the patient was working, the work-related nature of the injury should be documented as secondary diagnosis. This helps to indicate the circumstances under which the injury occurred, which may impact treatment and insurance claims. Question 30. A 50-year-old male presents with chronic pain in his left shoulder. The physician diagnoses him with rotator cuff tendonitis and prescribes physical therapy. How should this encounter be coded? A. Code for rotator cuff tendonitis with a secondary code for chronic pain. B. Code for rotator cuff tendonitis only. C. Code for rotator cuff tendonitis with chronic pain as the primary diagnosis. D. Code for chronic pain with a secondary code for rotator cuff tendonitis. Answer B. Code for rotator cuff tendonitis only. Explanation. The primary diagnosis is rotator cuff tendonitis, as it is the underlying condition causing the patient's symptoms and requiring treatment. Chronic pain is a symptom of the tendonitis and should not be coded separately. In cases like this, the condition causing the pain, rotator cuff tendonitis, is the main focus of treatment and should be listed as the primary diagnosis. Chronic is inherent in many musculoskeletal conditions and is not separately coded unless it is the main focus of the encounter.